Okay, so I'm going to introduce and then I'll hand it over to Russ. So integrated care systems, a real opportunity to do what it says on the tin, integrate care. But let's be honest, they are driven and weighted by the NHS. So there's so many reasons why we need to take this opportunity of system change to really genuinely integrate health and care. And that's why I'm delighted to be listening and introducing this panel of experts today who are going to look at the implications of the social care white paper on the future of ICSs. So now I'm going to hand over to Ross Charlesworth, who's head of integrated care, and he's going to introduce and moderate this session. And I'm really looking forward to listening to it. So thank you.
Thank you so much, Roz. Delighted you've all decided to come to our session today. Can I just check you can hear me okay? And just with the sound engineer at the back, are those mics on? Because I think the panel are going to stay seated. They are. Thank you very much. Just a quick tech check. I'll hand over pretty much to the three panellists. But before, I just thought it would be worth just doing a rapid recap of our theme. What we've chosen is two pending changes, if you like, in the landscape of the health and care that's going to form the kind of centre of our discussion today. You'll know that in July, 1st of July this year, there'll be 42 new legal entities up and down England, ICSs with various titles, and they'll become responsible for commissioning pretty much all of the health and care services that we'll consume. Some 100 billion plus spend. Secondly, on the 1st of December last year, the government published a social care white paper, finally, outlining a series of changes in the way that social care services will be organised, again, consumed by us. What is interesting, and maybe not a surprise to a few in the audience, is both sets of documentation made very scant cross-reference to each other. So two big structural changes in health and social care. So what are we trying to do today is considering, how might these pending changes impact health and care services? What could be different? What should be different? And what, frankly, is likely to stay the same? Is our industry, and does it have the appetite and the wherewithal to put the individual rather than service providers at the centre of the new ICSs? I think few people would like it. Is that going to happen? So, as you can see, I don't think we're going to have any shortage of talking points today. Just by way of warm-up, I'm going to throw two in. Social care white paper. Lots of the commentary before Christmas and after Christmas was, it took so long to come, and now it's nowhere near as ambitious as we would like it to be in terms of funding, etc., etc. Personally, I've taken a slightly contrarian view on that. It doesn't go anywhere far enough than it should have, but the direction of travel is good. And I was always taught not to look a gift horse in the mouth. So, yeah, it's not enough, but it's a step in the right direction. So let's capitalise on it. And then the second point is about ICS implementation. So yes, we're some way of it becoming legal. And there's lots and lots of discussion about the right technology and digital investment choices. Actually, I think that's a key part of it, but is it anywhere as near as significant of the cultural workforce and partnership working changes that we'll need to put in place? I think the technology is a super important enabler, but I think the human aspects of the resilience of workforce, how to organise, are going to be the bigger challenges and need some system thinking. Anyway, enough for me. I'm going to hand over, first of all, to Daniel Casson. He'll introduce himself, and then once he's finished, we'll hand over to Matthew Swindells, and finally, but not least, to Sam Smith. Once everyone's had a chance to put their points of view forward, we'll then flip to Q&A. I think there'll be a roving mic. There normally is in these sessions. If not, we'll just shout up and I'll look out. Okay, thanks.
Thank you, Ross. That's brilliant. My name's Daniel Casson. I'm an independent consultant in digital transformation in social care. Until 3 years ago, I was head of business development at a care organisation. So currently I work for Care England, the care umbrella body, as their digital transformation advisor. I'm part of the NHSX, or the old NHSX, sponsored digital social care programme, where we're translating NHS speak into social care speak for digital transformation. And I'm advisor to care providers and to tech entrepreneurs wanting to enter this space. My first point is in the theme of the Russ said of not looking a gift horse in the mouth. I want to trumpet the role of NHSX in what's happened over the past 18 months. I've been part of more consultation parties and conferences over the past 18 months than I ever have been with the NHS. In fact, I was instrumental with about 20 of us from social care in writing the tech part of the recent white paper. The consultation has been amazing. When they've realised the role is not to actually impose new solutions on social care, but help people make their own choices via standards. And that's the whole new paradigm and a whole new shift that I've been lucky to ride the wave of, in that they need people saying what's happening in social care and bringing them along with the right standards. So I've worked on the Digital Social Care Records programme in social care, sponsored by NHSX. And we've now got the UTF, Unified Tech Funding, going into social care via the ICSs. So we're now involved. Social care is now at the table. So I've got to trumpet that first of all. We now have a greater focus on health and well-being, and it's been I'm so pleased to be involved in HET because there's now a focus on the person. I spend half my time talking to people saying, let's not try and use the word patient. Let's look at the person as on their health and well-being journey. And I trumpet the words of Nigel Crisp in this: homes are for health, hospitals are for repair. And I've seen a lot of this today, for example, on virtual wards, and I think it's a fantastic programme. The one thing it doesn't do yet is incorporate the person as part of their community and support the carer for that person and the person themselves linking into all the community responses they can have. So, and the third thing I want to focus on, how ICSs and the white paper are going to make a difference, is that we are going some way to ensuring that housing and public health are part of the answer. I talk about the magic quadrangle of health, social care, housing and public health. And they are being brought together. Now, it's our responsibility to make that work. And it's our responsibility to actually take the things that we've been given, the gift horse that the Russ referred to, and make it work for communities and to bring people into that. I actually look into social care and say, sometimes as a social care provider background myself, that we don't make it easy to get that. It's not easy to find people to represent social care. And we need to make it easy for people on the ICS board to be able to hear the voices of social care, people who require care and support. So there's been funding in there, and one of my issues is we've got £150 million funding, for example, into innovation in care. Fantastic, the first time that's been there. One of the things missing is the funding system for the whole of social care has to be fixed before then so that we can actually invest in it, because we're talking about a lot of private individual corporations and community groups and not-for-profit groups that actually need to be able to invest in it themselves. That's a different model now that we're being involved in the decision-making, lots of individual social care organisations. So what I'm saying is we're at this point, we've got to take it on and bring all those factors in, and the person, I'm looking at a new model of care, not just the person at the centre of their care, but the person actually directing their care. Something I'm working on called the Equal Care Co-op, where actually the person and the person delivering the care and support actually work together to make sure that they're both included in how care is delivered. So there's some pledges in the white paper: 500 million for training qualifications, 150 million for technology support, 300 million to integrate housing into care strategies. Now's the chance. We've got to really take it. And I believe one of the ways we can do that is by ensuring all the information that we're collecting about people gets onto that shared care record so that people's journey can be mapped, and we talk about the whole person in this journey. Thank you very much.
Thank you, Daniel. Some really thought-provoking stuff there. Thank you. Matthew, over to you.
Thank you very much. And so I'm Matthew Swindells. Very excited about the fact that I will shortly no longer have to be referred to as former Deputy Chief Executive NHS England, and shortly to be the chair of the coming together of the 4 acute trusts in North West London. From the 1st of April. So that's going to be exciting. But it's good to be here and good to have this conversation, because as Chief Operating Officer and Deputy Chief Executive at NHS England, ICSs were my baby. And the idea was to bring together health and care. And they were envisaged, some of you will remember, 2 things about them. One is they didn't have this 2-board structure that they now have in the legislation, which frankly I don't think is a step forward, but it is what it is. The idea was to say to local authorities, come to the table when the NHS is making spending decisions. And there's no quid pro quo on this. We hope that the response will be, over time, that the NHS will be in the room when local authorities are making spending decisions as well. But we need to step forward in a positive way. And I think that approach of a focus on the needs of our populations rather than the needs of our institutions is critical to making any of this work. Because if we are dependent on structures and legislation and white papers and ministerial speeches, we won't actually create the set of cultural changes which gives staff in the NHS and the staff in local government and the staff in the voluntary sector permission to do what's right for the patient, rather than wondering what it's going to look like when they look up the chain. So I think there is, at the moment, too much focus on the ICS governance structures, when I think there are 2 other things that are very big that are going on at the moment, which, if the white paper on social care is going to have an impact, needs to dock into. The first one is everybody in the NHS is now talking about place. Really good interview question. Have they got any idea what they mean by that? Obviously, there is a spread. There are some people who really have a view on how that's going to work. I think if you go to Surrey, where the leader of Surrey County Council has been chairing the ICS for several years now, there actually is a conversation about what is meant by place. In other parts of the country, place is defined by the footprint of the hospital. So local authorities and social care have a much better sense of what place means, about the difference between the needs of different housing estates in the same borough. And local authority needs to come not disappointed to the table, but pleased that that conversation is now taking place, because I think there is a genuine desire across the NHS to do something at place level, to work out what that means. And there is very significant money being put into primary care networks at the moment. PCNs are receiving hundreds of millions of pounds, and it either becomes an extension of a traditional general practice model, or it becomes something very different in terms of proactive, predictive, interventional care identified for high-risk communities. And so I think there is opportunity there. The second thing that I think we shouldn't lose in the ICS discussion is that in the NHS's terms, nearly all the money is in the acute sector. And if the acute sector continues to generate a giant sucking noise for all of the money coming in, we're not going to have any money to do anything differently. So what will be my new organisation is spending £3 billion a year covering 2.5 million people. If in 5 years' time it's spending more money than that, it will have been a failure. Success will be its budget has gone down because people are being cared for in more appropriate places. But we are seeing the merger of, at managerial level, without the statutory merger of the acute sector all over the country in horizontal mergers. We're also seeing vertical mergers going on with acute, community and mental health coming together in places. And in some places, like East London, it's both. It's the acute sector and you're getting a single provider collaborative. There needs to be an engagement at that level, because very significant spending decisions are being made about the individual care of patients in that sector, and it's where 75% of the total NHS money is going at any moment in time. So I think at a borough level and at a place level, conversations with the acute sector about what it means to become not bigger but more local is absolutely crucial. Second thing I'd just like to touch on briefly is just around data. We need to move away from the idea that data belongs to institutions and towards the idea that data belongs to individuals. There are And if you take that approach, then you come to a very different view about how information governance works. You come to a very different view about how data is used. And if we take that approach, we then say, what do we mean by digital inclusivity? If we're going to do levelling up, then we can't have digital inclusivity for everybody who carries an iPhone with unlimited data. We need to be more interested in how do we reach out to people who don't have English as their first language, people who are paying on a pay-as-you-go basis for their data and for their phone, for people who don't get IT at all, and how do we use sports centres and libraries and pharmacies to create partnerships that are actually about the community supporting people to use technology. Like if you go to North Liverpool and you'll see the Carnegie Library saved in North Liverpool through a partnership with the Community Mental Health Trust. That kind of partnership can help revivify our high street as well as create something that is closer to people. So focus on where the money is, focus on how we design services around people, and let's make something bold happen around data.
Matthew, 3 brilliant points: place, data, and also, my words, not yours, the NHS having in some way or form having to concede territory at an ICS level if they're going to have an equitable care and service. Okay. Sam.
Thank you. So some of the areas that I'll pick up on have already been articulated very well from both Daniel and Matthew. Place is absolutely one of them, and data is another. So in terms of my perspective on life, my day job is as Assistant Director of IT and Digital Services for a county council and for a unitary council. And for anybody who isn't aware of the differences in terms of council structures, there's multiple tiers to local government. It's not a single thing. And in some organisations, if you're a unitary, that means that you are responsible for functions such as health, leisure, kind of parks, so housing, revs and bends, collections, so council tax, but also adult social care and highways and education. If you're not a unitary, then you won't be responsible for all those things. So actually, from a council perspective, life isn't particularly simple. And the geography that I'm in, the place, very much that my place is a complex one. We have one unitary, which I represent, that's Peterborough City Council, so that does all of those functions. We have one county, which I also represent, which sits around the top of the other districts in that county. And over the top of that, we also have a combined authority, which has some of the other, has devolved powers in other areas. And beneath all of that, you have town councils and parish councils. So when you start to talk about place is very, very important, but it's also very, very different. And it's not even as simple, and I'm just referencing back to the perspective of thinking of it as a borough. Actually, I can't think of it as a borough. I have to think of it either as a district or a county or as a town or a parish. And one of the conversations that we were having in an earlier session was around how successful ICSs can be a bit about how big they can be and how much, therefore, they can be challenged by that size. So if you do have a place where the geography it works and you are talking about a defined area that has its own identity, and if that's reflected in some of the other organisations, then potentially you can make more powerful decisions. And if you've got one that's actually quite large and quite fragmented, in my place, coming back to that particular perspective, we have Cambridge City. It's a unique space. We have Peterborough City, which is unique in its own way with different challenges, very different demographics between the two. We have some very, very affluent rural areas, and we also have some incredibly deprived rural areas. So none of those elements, in terms of my place, are the same. So from an ICS and also from a social care perspective, being able to make informed and granular decisions about how money is spent and how services are provided is incredibly challenging. And then if I look at the health elements of my place, coming back to that theme, we've got Adam Brooks, which is a world-leading hospital. We've got the Royal Papworth, another world-leading hospital. They're two incredible institutions. And we've also got another acute as well with and another trust. We've got a lot of GP surgeries as everyone else does. And we've got some significant differences, again, in terms of how the health provision is structured across that place. And all of that comes together in something that is really quite challenging. And that is one area of the country. And my geography, my place, my institutions, the context in which I work are not the same as anyone else's. So if you've got other areas in the country where you've got a unitary organisation that happens to be coterminous with a health organisation boundary. That would just be slightly jealous, if I'm honest. But, you know, there's challenges that come with that as well. But it's how we can work through what place means. And it is absolutely vital that that is understood to be different in different places and utilised constructively from that perspective. So that's the place element. The data piece, coming back to some of the points that Daniel made, the social care providers, God bless them, I don't know how they manage. I really don't. So they're the neglected, underrepresented people that provide the most incredible services, and it's very difficult for health to engage with them directly because they're fragmented individual and typically private organisations, and it's also incredibly difficult for local authorities to represent them because they're individual organisations, and yet health expects social care to be able to represent providers, but it doesn't work like that, and the dialogue gets very complicated, and Daniel, I'm sure, can speak more to it, but it's how data can then flow through, and we can create a shared healthcare record between health and care. What about the providers? How does that data work? Because that's really important as well. Yes, that's my perspective.
Sam, I think the perspectives on place there and the dynamics and the differences between city, urban and rural differences, I think you might go some way to answering Matthew's exam question around, so if you find yourself in front of Matthew in an interview situation, you've got a pretty good answer there, I think. Look, what we're going to do now, if it suits everyone, is we're going to open questions up to the floor. I know Matthew's got a hard stop at 3 o'clock, so if you've got any particular questions that you want to channel specifically to Matthew, let's try and do those first, but we'll continue beyond 3 o'clock for any other questions. So there's... Okay,
this is where we find out that no one cares whether I'm here or not. Now I feel under a lot of pressure.
Well, I hope I haven't set you up for four. No, there's a question coming now.
I care.
Thank you.
Hi, my name's Alex. I'm from Surrey and Borders, and I find it really interesting what you're talking about around the amount of money that's going into acute. And I've got two questions, but they do lead on from each other. So one is around the ICSs, and actually, at the moment, and I know it's not the intention, but it does seem to be around who shouts the loudest and the power dynamics. So how do we think the ICSs can help support, so that it's not just the acutes getting the money, but then following on from that is that, again, where there's a lot of focus of trying to turn to prevention. So how do we stop people getting to hospital? But again, there seems to be a fundamental lack in cultural change across the board to really focus on that prevention area. So it'd be really interesting to hear your thoughts on that.
Yeah, no, I think it's a great question. I know the patch because I was chief executive at the Royal Surrey for a number of years. So, and if you can't do it in Surrey, you can't do it anywhere to an extent, given your population. So I think there's a couple of elements there. I mean, when we say all this money is going to the acute sector, it's not that the staff are sitting around eating pheasants for lunch every day. They're all overspent and they're all under pressure, and it is one of the tragedies of the NHS that every hospital in the country is exactly one ward smaller than it needs to be. And I mean, who knew? So in order to change it, firstly, it can't be done through a fight. A knockdown, drag-out fight with the acute sector when the media will always lead on ambulances that can't unload, people waiting 2 years for their surgery. It has to be a collaborative discussion about how you do stuff better. So if you take a deep breath and take a step back, about 30% of all of the patients lying in an acute hospital bed today shouldn't be in hospital. And it's not that there's nothing wrong with them. They all need some sort of care. But being in an acute hospital is certainly doing them no good compared to the ideal place, and quite possibly is keeping them on an elderly care ward until they catch the infection that's going to kill them. So you wanted to be dramatic, you said there are people being held against their will in acute hospitals because we can't get our act together as the health and care system to put them somewhere better, and better is almost certainly cheaper than keeping them managed in an acute hospital. So that is the grand challenge for us, is of those, what adds up to 30,000 beds across the NHS, about half of them have dementia. So what they are is in a place of safety. And if we can't create the facilities for people with dementia to be looked after somewhere else, they will fill up the acute hospitals, and you will both have all the money going into the acute sector to cover that. Most acute hospital beds are now full of elderly patients. They're not full of people waiting to have their hip replaced. That's the olden days. So we have to have a focus on how do you fundamentally redesign service. And if you want to do it, you have to do it, if you like, 10,000 bed days at a time, because that's how many it takes to close a hospital bed, a hospital ward. Taking 3 elderly patients out of the local acute hospital doesn't release any money at all. You have to do it a chunk at a time, which means you have to do at-scale solutions to these problems. So the short-term answer is that it's why are people turning up at A&E when they should be being cared for in primary care? Why are they turning up in primary care when they should be cared for in a pharmacy? Why are they still in hospital when they shouldn't be in hospital? Why are they being referred into outpatient when you should be able to get a diagnostic test without going anywhere near a hospital? We have a complete kind of misflow of patients. And then the longer term question is, what are we going to do about self-care, people supporting themselves to be weller, but trying to impact on this year's budget by making the population healthier is a category error. You know, you have to do both things. What are we going to do to impact today's spend in order that we can move money? And what are we going to do to create a healthier population over 5, 10, 15, 20 years?
I couldn't agree more, and I absolutely see that from a local government perspective, and also in my role as Socatum, working with them in terms of policy and research, we're looking to see how we can create resilient communities and healthy people to ensure that we tackle that second part, so that people are healthy, well, cared for, able to look after themselves. And fundamentally, sometimes that comes down to ensuring that not only are they healthy and well, but they've got somewhere to sleep. They know where they're going to be living, because you can't look after yourself from a health perspective or any other way unless you know that your basic needs are going to be met. If you're thinking about where you're going to be sleeping, how you're going to be feeding yourself, how you're going to be meeting the bills, you are not going to be thinking about, am I looking after myself? Am I doing the best thing for my long-term health? You're just not going to be doing that. And that, a lot of the things that affect that, sitting local government can control with funding issues that we can't begin to explain at this point, but it also is fragmented at that level as well. So I do think that there's some really, as well as that health complex discussion about how that's done, there's the wider and the earlier determinants of public health come into that as well.
And you, doctors have this strange ethical objection to discharging people back to sleep on the streets. You know, so when I worked in London and I worked in Slough, that was a genuine issue, that there were people in hospital because there was nowhere to discharge them to.
I think I want to get to the practical issues here, because what you're seeing, what Matthew and Sam have just said, is because there's a lack of, the worst, a lack of respect, at the best, a lack of understanding of what's out there, the possibilities that are out there. So one of the practical things I'm working to try and get involved in is actually joint training for health care staff, where you're bringing people together in a practical situation. If you want to hear the NHS slagged off, there's no better place to go than a home care organisation or a care home. And I want to get rid of that, because that was really dispiriting. Because they say, I sent one of our residents to hospital, then they moved ward, and I had to tell the hospital, the new ward, the information about this person. It wasn't passed on. So we're lacking that mutual respect. And once we build that up, yes, there's bigger problems than that, I understand. But once we start people working together and respecting them, we've had this with GP Connect, for example, which is going into care homes. But they won't allow carers to have access to the information because they're not registered professionals in a health view. Once we start having the mutual respect in the care and community, then clinicians will actually trust who they're discharging, where they're discharging people to. So basically, I want joint training and joint respect systems to be put in place.
Well, there was a cultural change element, I think, in your question. I think what we've seen from the 3 panellists here is different perspectives, but it is about that fundamental change. And I think we need some systems thinking with the new ICS leadership, which isn't about big is beautiful, isn't about the old world control totals, it is about making sure they do the right. Of course, place is different for all the 42 ICSs. I think hopefully that's come across today.
I'm going to abandon you. Thank you very much.
We don't consider it abandoned. So thank you, Matthew, and sorry you couldn't stay a bit longer, but thank you for Brilliant. Thank you.